And what we have is that the volume of the thoracic cavity and the lungs are going to increase vertically when the diaphragm contracts or flattens, as well as laterally when the parasternal and external intercostal muscles raise the ribs. So then what we have is that the thoracic and the lung volume is going to increase, whereas the intrapulmonary pressure is going to decrease. And so what this allows for is for air to come in. And so the pressure changes that we observe are with the alveolar changes. What we have is from a 0 to a -3 millimeters of mercury, now from sea levels, okay, not at 0 to -3, okay? So this is the range that which it changes. Also, we'll have the intrapleural pressure change from -4 to -6 millimeters of mercury, and the transpulmonary pressure of +3 millimeters of mercury. Again, not as a final number, but rather this is the range. So you see it's very small in terms of inspiration for this to occur. And so no surprise here with expiration now, the volume of the thoracic cavity and the lungs are going to decrease vertically when the diaphragm relaxes and creates that dome shape. And also laterally when their external and parasternal intercostals relax for quiet expiration, or when we have the internal intercostals are going to contract and force expiration, and that helps to lower the ribs. So here, again, the thoracic and the lung volumes are going to decrease, but now the intrapulmonary pressure is going to increase, and so this is going to force air out. And so when we look at the pressure changes, the intrapulmonary pressure changes from -3 to +3 or +3 millimeters of mercury, again from atmospheric pressure of 700 millimeters of mercury, not all the way down to -3 to +3. All right, so then the intrapleural pressure is going to go from -6 up to -3 millimeters of mercury, and then the transpulmonary pressure is going to change to +6 millimeters of mercury. Again, all of these from atmospheric pressure levels. So let's look at a diagram now of inspiration and expiration. So here we have at rest, okay? So at rest, we're going to have the atmospheric pressure be 760 millimeters of mercury. So intrapulmonary pressure is going to be at atmospheric pressure, and then intrapleural pressure is going to be a little bit lower at 756, again due to the frictional forces within the lungs. All right, so then when we have inspiration here, what will happen is that we will have an intrapulmonary pressure of 757 millimeters of mercury, and then intrapleural pressure to 754. Then with expiration, what happens is that we have now a change again. So now we're raising it to 763 millimeters of mercury for the intrapulmonary pressure, and then the intrapleural pressure will also rise to 757. So then that's going to force air out based on diffusion concepts. And then whereas here, now these are lower than atmospheric pressure, so that's going to force air in. So there are several tests that we can do non-invasively that will determine your pulmonary function. And so this is done with a spirometer that you'll practice this within the lab. And what we have here is that you breathe into and out of a device, and then the air movement is going to be measured on a spirogram. And so this will essentially measure your lung volumes and your lung capacities. So in general, when we're looking at one of these graphs, when we have an inflection or an increase, such as with these peaks here, this is going to represent an inspiration. Okay, so this is when you're breathing air in. On the other hand, when we have a deflect, where such as here, let me highlight that better, there we go, and it goes in here, bringing it down, this is going to signify exhalation or having air out. Okay, so now let's go through some of the terms. Again, this is probably practice from what you've had in lab or what you will have in lab if you haven't had it yet. Okay, so let's look at tidal volume first. Tidal volume here, this is going to be the amount of air that's expired or inspired during normal quiet breathing. the next one, the expiratory reserve volume, which we find here. So from this arrow to this arrow, all right, so we're looking at from tidal volume to like a maximum amount that can be exhaled. This is the amount of air that can be forced out after tidal volume. Next, let's look at inspiratory reserve volume. So here we have this. So this is from the tidal wave and then maximum amount that can be inhaled. And so this is the amount of air that can be forced into the lungs after tidal volume. The residual volume, what we have here, this is the amount of air that's left in the lungs after maximum expiration, commonly known as dead space in the lungs. Okay, this helps to prevent the lungs from collapsing on one another. Then we have vital capacity, and so this is from maximum air in to maximum air that can be exhaled after maximum inhalation. So this is the amount that can be of air that can flow through one's lungs. Okay. Total lung capacity, what we have here is going to be our vital capacity, which again was here, plus then that residual volume of the lung space, so the complete amount of gas in the lungs after a maximum inspiration. Okay, so the next one that we'll cover is this inspiratory capacity. So this is when we have the amount of gas that can be inspired after normal expiration with your tidal volume. So here we start, everything's exhaled from your lungs, and then you inhale as much as you can. Okay, then what we have is this functional residual capacity. And so this is going to be the amount of gas that's left in your lungs after normal expiration. Okay. So what you can see here too with the functional residual capacity, so this is going to be the expiratory reserve volume plus the residual volume. With pulmonary disorders, there are two main classifications that are found. We have restrictive and obstructive disorders. So restrictive disorders are when the lung tissue becomes damaged. The vital capacity becomes reduced, however, the forced expiration is normal. Example of this would be pulmonary fibrosis, which is connective tissue that's found or scarring on the alveoli of the lungs, and then emphysema. Obstructive disorders are when the lung tissue is normal, and so vital capacity is normal, however, the forced expiration is reduced. An example of this would be asthma and bronchitis. So obstructive lung diseases include conditions that make it hard to exhale all the air out of the lungs. And people with restrictive lung disease have difficulty fully expanding their lungs with air. So both of these, though, however, share the main symptom, which is shortness of breath with exertion. So now one difference too is that with the obstructive disorder, the forced expiratory volume is going to be less than 80%. So that's one clinical diagnosis that will determine the difference between obstructive and restrictive disorders. And so if we look at this figure here now, what we have is normal breathing, and then we have an obstructive disorder and then restrictive disorder. So as it says here, so with point A, what we have are normal quiet breathing, so it's our tidal volume. So looking at point B now, we're looking at point of maximum breathing. So what you can tell right away is that if we draw our line for the normal, then the restrictive has a decrease in the maximum amount of inspiration. And then the obstructive, what we find here, is a decrease in the expiration, okay? And so you can see too that it takes longer, this is what this line is denoting, to exhale all that air out of the lungs, even as compared to restrictive breathing itself. So any category that falls under the term of shortness of breath is considered to be a dyspnea. So from a dyspnea, what can be more specified then is what the classification of that dyspnea is. So let's begin by looking at COPD, or chronic obstructive pulmonary disease, which I'm sure a lot of you have heard of. And so one of this is going to be, that falls under this category, is asthma. Okay, So with asthma, what happens is that there is an obstruction of airflow that occurs through the bronchioles. And so this is either due to inflammation and mucus secretion. Inflammation is going to contribute to the responsiveness of agents that promote bronchial constriction. Okay, so two examples of this would be an allergen, so an increase in your IgEs, immunoglobulin E's, and then also we can have exercise-induced asthma. So if we look at this picture here we have a normal bronchiole and here we have an asthmatic one, and so you can easily tell the difference in the lumen is going to be a lot smaller from the asthmatic as compared to the normal, and so this is showing this red as inflammation of that bronchiole as well. So now examples of pulmonary or restrictive pulmonary disorders include emphysema and pulmonary fibrosis. And so with emphysema, what happens is that the alveolar tissue becomes destroyed and there is a progression of a decrease in surface area for gas exchange. And so this is going to be caused primarily by cigarettes, okay? And so smoking of cigarettes and the tobacco there stimulates macrophage and leukocytes, the white blood cells, to then secrete proteins that are going to digest with their enzymes. And what that does is that decreases and eats up at that alveolar tissue. And so if we look here, we have the normal bronchiole and alveoli, and here we have emphysetic one. And so here you see this nice cluster of alveoli, lots of surface area for lots of gas exchange. However, with emphysema, here, while it appears that these clusters are larger, however, if you notice, there's a decrease in surface area. So being larger does not always necessarily mean being better. So unfortunately, decrease in gas exchange. Again, number one cause smoking, so for emphysema, so this can be prevented easily. Another restrictive disorder is pulmonary fibrosis, and this is where we have an accumulation of fibrous connective tissue proteins. And so this is commonly observed within minors, and so this is termed as the black lung. And so here we have an example on the right panel of that black lung versus that of a healthy individual. And so this is caused by the carbon found in the coal mines that they have to work under. And so over time, this will actually turn into then emphysema as well.